Good afternoon, nursing students. Today I'd like to lecture on Chapter 16, which revolves around metabolic stress. So we're going to look at third-degree burns, major trauma, and major surgery. So make sure that you pay attention to the medical nutrition therapy that is involved with all of these medical conditions. Let's begin. There are a couple ways that the body responds to stress. It could be psychological, it could be physical, and we typically see at the beginning of the process inflammation results. Inflammation involves the central nervous system and also different hormones, as we'll see in the subsequent slides. The severity of the inflammation is determined how long the stress is present. The immune system is very intricate and very complex. The immune system is one of the first of the bodily functions affected by impaired nutrition status. So for example, we talk about vitamin C in assisting in viral and preventing viral replication, which is true. So when you do have cold symptoms, the recommendation is to increase your vitamin C food sources, but also increase your vitamin C supplementation. It is also true now that we're in a pandemic with the rise of COVID-19 cases, it is recommended that you supplement with vitamin C to help prevent viral replication. During times of hypermetabolic stress, that's when your basal metabolic rate increases, nutrients become impaired. So when nutrients are impaired, that means there's decreased absorption. It in turn affects the mucous membranes. There's also degradation of the skin. Your GI tract is affected. And we'll see on the CBC, there's an increase in white blood cell counts, T lymphocytes, macrophages, granulocytes, and antibodies. So let's look at malnutrition as a whole. We talked about malnutrition several times throughout this nutrition course for nurses, but let's break down the affected parts of the immune system by malnutrition. So we can see that diet and nutrition, the status of the patient influences microorganisms, especially in the gut. And if the gut is not functioning at 100% capacity, then we'll see a decreased immune response. Integrity of the skin and mucous membranes are diminished. There we see decreased wound healing, especially in patients in long-term care facilities. Remember, in the small intestine, we see the flattening of the microvilli, which in turn decreases nutrient absorption. We also see damage to the GI tract, which there is that correlation with damage to the GI mucous membranes and increased risk of infection causing bacteria. Not only will the infection begin in the GI tract, but it can metastasize outside of the intestinal system. We also see in a patient with malnutrition that they don't have a lot of antibodies. So their antibodies tend to decline and are less efficacious, meaning they're not as effective. This picture depicts how malnutrition is a vicious cycle. So malnutrition is undernutrition. When someone is overweight, obesity, morbid obese, we call it overnutrition. So this figure depicts that gut microbiota will serve as a barrier to infections. The pathogens decrease absorption, decrease immune functions, and because this barrier is often disrupted, malnutrition is present. So you can kind of see it becomes a vicious cycle. I want to spend some time going over the stress response. I think now many of us feel during a pandemic that we have increased stress. And we'll talk about some examples of patients that may experience stress. So anytime that a patient presents with a fracture, they were in an MVA, so a motor vehicle accident, GSW, gunshot wound, major surgery, third-degree burns, whatever stress your patient is in, the response is fascinating, but it's yet a harmful one on the body. The body over time can continuously and constantly adapt to minor changes, so that's called general adaptation syndrome. You've heard the term, it's coined fight or flight syndrome. It affects the parasympathetic system, which then feeds on the hypothalamus, which is the thirst, sleep, and hunger flagship in the brain. And that affects the stress of the entire body. So let's look a little further and see some of the adaptations that the body responds to under stress. And these are primarily the initial responses to stress that the body undergoes. So what this flow chart depicts is that chain reaction involving that parasympathetic nervous system and the hormones that affect the entire body. So all these responses, we call that fight or flight response or general adaptation syndrome. So for example, like during the caveman days, they either, if they saw like a bear coming, they either had to fight the bear or get out of there, meaning flight, so run. So let's look at some of the effects on the body in response to this stress. So, for example, heart rate increases, so tachycardia, blood glucose levels increase, so hyperglycemia, hypertension, pupils dilate, breathing rate increases, and then again, the flattening of the villi, meaning the intestinal muscles will relax, that increases motility, so the patient could result in having diarrhea. Okay, this next slide is very complex because it involves hormones again. We're going to look at stress hormones. I want to go over the 4 categories because those are involved in shifting either fluid or electrolytes to help the body adapt to this stress. So the first one is aldosterone. That's a corticosteroid that functions in the kidneys to retain sodium. ADH is antidiuretic hormone that promotes the conservation of water and sodium to help retain blood volume. Then we have ACTH, which is adrenocorticotropic hormone. Very long name. What does it do? Well, it releases cortisol. Cortisol, in turn, will call on the amino acids in the skeletal muscles and say, hey, we need some energy. You can't build muscle right now because we need the amino acids for energy. So what happens in turn is that we will see denaturization, degradation of lean body mass over time. And those of you that work in skilled care, nursing homes, will see that in your residents. The last one, catecholamines, those are more heavily relied on the nutrition process. You're familiar with them, epinephrine, norepinephrine. Those stimulate the nutrition metabolic pathways, which is glycogenolysis, the breakdown of glycogen into glucose. So we're needing that glucose for energy now, fight or flight. Fat mobilization, meaning we use fat for energy. And gluconeogenesis means we're producing glucose from non-carb sources such as fat and protein. So some of you, when I was reading your food journal papers, consume too few calories on some days. And most of the time I noted that when you were on the floors or you were working or maybe taking care of your family, you weren't really taking care of yourself. But over time, if you consume too few calories, you put your body at risk for starvation. So you go into what's called starvation mode. And so what happens is you utilize your stored macronutrients. So you utilize blood glucose, then it's glycogen that's depleted, and then we call on fat, and then lastly protein or amino acids. But over time, your stores are depleted and your BMR, or your basal metabolic rate, would decrease. So it's important to get those calories you need, even if you're trying or attempting to lose weight. So glucose, really important to note here that glucose is needed for the brain and red blood cells. Glucose can only cross the blood-brain barrier to make red blood cells. So you do have that risk of when you are on a low carb diet or no carb diet, like the keto diet, you utilize non-carb sources, and that could put you at risk to go into ketoacidosis. Let's look at severe stress. The major difference between starvation and stress is that the metabolic rate decreases during starvation, so you have a lower BMR, and increases during recovery from injury. There are two phases during severe stress that I want to review with you. It's called the ebb and flow phase. The ebb phase is the early phase of severe stress, and it occurs immediately after injury. Typically characterized by decreased oxygen consumption, hypothermia, and lethargy. Usually 36-48 hours post-injury, then the body goes into what's called the flow phase. So the body is severely stressed, and here you can see the opposite occurring. Increased oxygen consumption, hyperthermia exists, and there's catabolism, so breakdown. So when you talk about catabolism, you're going to talk about a high nitrogen output. It could last for weeks, days, months until the injury is healed. If the patient goes into severe stress and is nutritionally depleted, it really exacerbates the problem. And so it's important to note the protein requirements that are required there at a really all-time high rate. So if you remember, a normal protein requirement for somebody that is healthy is 0.8 grams per kilogram of body weight. Moderate stress is 1.0 to 1.5 grams per kilogram of body weight. And moderate stress is surgery. Patients that undergo major surgery, and I'll give you an example of a total hysterectomy, that would be moderate stress. Severe stress, the protein requirements are 1.5 to 2.0 grams per kilogram of body weight. And severe stress is any type of burn. So it could be thermal burns, chemical burns, and deep pressure ulcers. They're going to require the most dietary protein. So we'll go over an example of a patient that is status post total hysterectomy and go over how you calculate that in lecture. So registered dietitians utilize different mathematical formulas to ascertain energy needs, and it's based on the patient's hypermetabolic stress. The one that I use on the floor, especially in ICU when I was working with COVID patients, is called Harris-Benedict equation. You will not need to calculate energy requirements using these mathematical formulas because you would leave those up to your fellow dietitians. But it is important for nurses to know with regards to fluid requirements. So fluid requirements are based on age. Adults that are younger than 55 years of age will tend to need more fluid, 35 to 40 mLs per kilogram of body weight. Adults that are between 55 and 65 years of age will need a lower amount of 30 mLs per kilogram of body weight. And adults that are older than 65 years of age will need the lowest amount of 25 mLs per kilogram of body weight. I'd like to just review the effects that stress have on the macronutrients and fluid metabolism. So typically what happens to blood glucose levels post-surgery is that they increase. Sometimes we'll see patients who do not have a history of type 1 or type 2 diabetes with elevated blood glucose levels, sometimes into the 300-400s post-surgery. It's called stress-induced hyperglycemia, and they will in turn need insulin. And it's just for a temporary period of time. In terms of fluid status, hydration, we will see an increase in fluid losses from various stresses, and you should be familiar with those. So examples would be if a patient is febrile, is experiencing diarrhea, wound drainage, like third-degree burns, there's drainage from the skin area, and then also if somebody or a patient is receiving diuretic therapy. Protein in the muscle, in the skeletal muscle, is mobilized for energy, so that's the effect of stress on protein metabolism. So there's a decreased uptake of amino acids by the muscle tissue. Why that is we're conserving them for energy. So you would expect that nitrogen excretion is increased, and the amino acid that we use that plays an important role during stress on the GI tract is glutamine. It helps to serve as a fuel source in the intestines. It helps to enhance wound repair. And so sometimes in enteral and parenteral nutrition, we will add glutamine to patients that are undergoing severe stress. The fatty acids from adipose tissue are used for energy, which in turn results in elevated levels of the catecholamines. Insulin production decreases, and why is this important is because malnutrition contributes to what's called MODS, multiple organ dysfunction syndrome. Malnutrition can also lead to sepsis, like MRSA, and then eventually death. The effect of stress on vitamins and minerals, as you can imagine, the need for vitamins and minerals increases overall. However, if a patient is meeting their calorie needs, then they're most likely receiving adequate amounts of the micronutrients. However, vitamins A, C, and zinc are known as the healing nutrients, especially post-surgery. So we will pay special attention to those, and if the patient is receiving alternate feedings like enteral or parenteral, we will supplement with those nutrients. We recommend between 500 and 1,000 milligrams of vitamin C. And in the form of zinc sulfate, we recommend 220 milligrams daily. Gastric bypass surgery, also known as bariatric surgery, is taken on many forms, including gastric bypass, sleeve gastrectomy, and the procedure, the newer one that's talked about in your ATI book, is the Roux-en-Y gastric bypass. This is major surgery. There's many complications that occur. We do have criteria for bariatric surgery, and it's based on BMI, so BMI that's greater than 40 in patients that do not have any coexisting medical conditions would meet the criteria for bariatric surgery, or a BMI greater than 35 with comorbid conditions. This is, like I said, a major surgery. There are complications. We typically see patients post-bariatric surgery come back to the ER a few times. They're in extreme pain. So it's something that needs to be taken seriously. However, it can be recommended in morbidly obese patients that have uncontrolled type 2 diabetes. High-risk surgeries include bypass surgery, so triple, quadruple bypass surgery, hip replacement, and prostatectomy. Those are all high risks. The best indicator when it's safe to resume GI intake post-surgery is the presence of bowel sounds. It's not the gag reflex. It's not if a patient is hungry. It's not if a patient can sit in a semi-flowers position or if the blood glucose is normal. It is when you hear hyperactive bowel sounds. Which brings me to my next issue about acceptable blood glucose levels post-surgery. We like to see it between 140 and 180 milligrams per deciliter. We'd love to have it in that 100 range. But again, remember stress-induced hyperglycemia. We see that gluconeogenesis breakdown and glycogenolysis. So there's all this glucose flooding to the blood. The patient is stressed, their status post-surgery. So again, patients that do not have a history of diabetes could experience stress-induced hyperglycemia and would require insulin post-surgery. It's definitely not uncommon. When we look at traumatic medical conditions. It's typically involving the brain, so traumatic brain injury, brain surgery. Patients are definitely hypermetabolic, they're catabolic. We definitely see those catecholamines kick into gear, which in turn increases that BMI. Anytime there's brain involvement, there is a risk of aspiration. So typically we recommend a swallowing evaluation, a video fluoroscopy to determine if oral feeding is safe. And if we need to modify the diet with thick liquids, or modify the actual consistency of solid foods to mechanical diet or puree diet. So that is important to remember with any type of brain injury or brain surgery secondary to carcinoma. There's also trauma with patients experiencing spinal cord injury, especially a secondary to gunshot wounds. They do have increased nutrition needs. However, just remember later down the road when they're recovering, they're going to need less calories to prevent excessive weight gain. And the reason, as you can imagine, is because they're not going to be as active. To touch on MODS, which is multiple organ dysfunction syndrome, it's defined as the progressive decline of two or more organ systems at the same time, simultaneously. Typically, we see it in ICU, CCU, following trauma, severe burns, infection, and sepsis or shock. Unfortunately, the outcome isn't great because what happens is the organs start to shut down. Usually there's an uncontrolled inflammatory response, leads to multiple organ failure and eventually death. To look at MODS a little bit further, we see the increase of the catecholamines, epinephrine, norepinephrine results in increasing the BMI at a really high state. They're in super hypermetabolic state. From a nutrition standpoint, we're going to increase those calories, increase the protein. We're going to recommend early enteral tube feedings to maintain the integrity of the gut, and do as much as we can from a nutrition standpoint for them. Let's look at this graph. X-axis is nitrogen excretion, y-axis is the number of days. So we're looking at nitrogen losses in various stress states. So you can see that the largest nitrogen loss protein, which is analogous with nitrogen, comes from third-degree burns, followed by major trauma, minor trauma. So, if you had to choose between a bone fracture, a low-grade fever, minor surgery, or third-degree burns, which is the most stressful physical trauma based on nitrogen losses, it would be the third-degree burns. Because serious burns result in significant increases in that metabolic rate. We see the highest nitrogen excretion, fractures, low-grade fevers, minor surgery, they're also increasing that metabolic rate, but to a lesser degree than third-degree burns. To review burns, causes of burns include either thermal injury or non-thermal injury. Non-thermal injury encompasses chemical, electrical, or radioactive burns. It's important for nurses to know the symptoms of first, second, and third degree burns. So to review first degree burns, typically you'll see reddening of the area, no injury to the subcutaneous tissue. An example would be of a sunburn. Typically takes around 3 to 5 days to heal. We don't tend to see any scarring on the dermis. With regards to second degree burns, we tend to see reddening, of course, like in first degree burns, but adding blistering, taking weeks or months to heal. So there is a superficial thickening and a deep partial thickness of the injury. Third degree burns entail a full thickness injury, so it destroys the epidermis, the dermis, and the underlying subcutaneous tissue. Third degree burns tend to affect and reach the muscle as well. They do not heal on their own, and painful skin grafts are required by a surgeon. So I have a story when I first started my internship at Stroger Hospital. The first day I was in the burn unit as a dietetic intern. And my first patient was Malika. Malika was an 18-month-old girl. She was admitted to the emergency room and then admitted to the tertiary unit at Stroger. And Malika's mother's boyfriend decided to dunk her in a bath of scalding hot water. So she had third degree burns from her neck all the way down to her lower extremities. And to this day, I'll never forget her face. It was my first rotation at Stroger. And the great news is she did survive. She had numerous skin grafts done, and she did quite well. She definitely was a fighter. So it's important to note, as I mentioned before, with third degree burns, when the muscle is exposed, that is typically down to the thickness of the subcutaneous tissue and muscle, and that is typically we'll see that in third degree burns. This is a great picture of the depth of the burns and what layer it affects with the epidermis, dermis, subcutaneous tissue, and then muscle as well. And you'll find this in your textbook by Grodner. The burn patient, there are complex patient care. There's significant considerations with regard to fluids, pain management, wound care, infection control, and of course, nutrition support. Typically, for nutrition, during the first 24 to 48 hours, that's very crucial, and we focus on fluid and electrolyte replacement. Nutrition support is administered during this time as the patient typically has an MPO status. You may have learned in health assessment, or perhaps you'll take it next term, the rule of nines to ascertain total body surface area, which is TBSA, and in Grodner on page 334, it depicts that percentage of how we determine fluid and electrolyte replacement based on the TBSA. So it's used to estimate the extent of the burn and determines nutrition therapy with regards to fluid needs and energy needs. I will not be testing you on the TBSA calculation in nutrition, but you should be familiar with the term. Thermal injuries will only heal, the wounds will heal only when a patient is in an anabolic state. So with that said, we initiate parenteral nutrition as soon as possible within the first few hours. We usually initiate a solution called Ringer's lactate solution, which is a mixture of sodium chloride and water. The goal is to switch to enteral feedings after hydration. I won't test you on the Curare formula, but know it's the greatest influence on energy needs for a patient with third-degree burns. So we base it on the percentage of TBSA. The site of enteral feedings are also extremely important for the burn patient. It's critical to find the best enteral tube feeding route, and typically for burn patients we'll feed into the stomach, so a gastrostomy or G-tube. Only when the patient is at risk for aspiration will we feed into the jejunostomy or J-tube. We will not be going back to parenteral nutrition because the gut is functioning, and again, you want to maintain the mucosa of the gut. And lastly, I just want to leave you with the benefits of early enteral nutrition. And like I said, we will initiate parenteral nutrition within the first few hours, and my goal is between 4 and 12 hours is to initiate enteral tube feedings for a burn patient. A burn patient, as you can imagine, has significant fluid losses. We see fluid losses from sweat, from their wound drainage. So the best way to monitor fluid balance is to weigh the patient daily, hopefully at the same time each day. But looking at this slide, I mean, there's so many advantageous benefits to tube feedings. It helps to maintain the mucosal gut lining. It helps to meet their nutrition needs. It improves feeding tolerance, decreases that incidence of bacterial translocation so they don't get an infection. Early enteral feeding, some of the studies have shown that it decreases the need for antibiotic therapy. We see the patients with enteral tube feeding more so in positive nitrogen balance than those that are fed with parenteral nutrition. It decreases the need for insulin. It decreases the hypermetabolic stress, and it also increases the visceral protein status. So when we look at total protein, albumin, and serum albumin, we see them within normal limits when someone is fed on enteral feedings when they're on the burn unit. Okay, that's all I have, and I will see you in lecture. Thanks.